So the objectives that were given are to develop an approach for diagnosis of acute red eye and to identify some red flags for red eyes, and also give you a little framework for how to manage common specific eye conditions and when to refer. So because I'll be basing my talk quite closely related to the structure of the eye, I thought I'll just revise what you already know, how the eye is structured. So there's the front of the eye, the cornea, that is the anterior chamber. Just behind it is the iris, the lens, and what we call the posterior chamber. That's the sclera, the muscles attached to the eye, and I'll be talking through each one of them as the pathology comes up. So in a GP practice, what you can look in an eye exam is basically if you subdivide it into structure and function, that covers quite a reasonably comprehensive eye exam. And all you need is just a few things that are shown in the photograph. Basic chart for distance and near vision, a torchlight, some anesthetic eye drops, and fluorescein. And if you think of the eye as a multi-layered structural organ, you can just go from the front to the back. So just start with the eyelids, the cornea, which you can look with and without fluorescein. There's the conjunctiva, the sclera, the anterior chamber, and the iris and the pupil. And all of this is quite easily examined just with a torchlight for basic, significant pathology. The alignment is something else that you can train yourself to look at, because you could have good alignment or bad alignment that could be a marker for an underlying pathology as well. And a red reflex. So a lot of people think of red reflex to be specific with pediatric ophthalm, but you can actually look at red reflex even in adults, and that gives you quite an indirect assessment of how their fundus health is, which I'll come to later. Function of the eye is vision, whether the pupil is reactive or not, and the structure of the pupil is round or not. So whether its functioning is whether it's reactive, and how the eyes basically move. It's important to check vision with a pinhole, because that does tell you whether there's a refractive component that can be improved with just eyeglasses if their vision is down. You can make your own pinhole just by stabbing a pen through paper, or you could get one of these ready-made ones. So what are the possible structural problems that you might see in your day-to-day practice that come in with the eye? So eyelids are notorious for different types of lumps, redness, discharge, infection, or a bit of cellulitis, foreign bodies, injury, swelling, and important to also note symmetry. So sometimes looking at both eyes together, you can pick up any eyelid problem. Cornea, common things are abrasions, foreign bodies, sometimes corneal haze, size of the two eyes of the cornea, the color of the cornea, and symmetry. So I put symmetry in italics just because a lot of the time people are looking just at one eye at a time, and you might miss a pathology if you don't look at both eyes together, because comparing a normal eye and an abnormal eye might sometimes give you more information than just by looking at one eye at a time. Conjunctival redness, extremely common, sometimes scleral redness. You can have conjunctival foreign bodies and trauma. Anterior chamber also, what to look for is basically, is it clear, and does it have any abnormal contents, namely blood or pus within it? Also symmetrically, are they equally clear in both eyes? Iris and pupil, are they round? Do they have similar size and shapes and reactivity in both eyes? And alignment of the eyes, are they straight or not? Now, using a direct ophthalmoscope, you can judge the red reflex is healthy in both eyes, but you could also use different phone apps, or just use a smartphone with a built-in flash that can give you a pictorial representation of how the red eyes can look. So that's just some examples of phone photography catching different sorts of red eyes, normal red eyes, and if there's a slight abnormality or looks yellow, or a difference that could pick up a lot of posterior segment pathologies. Eye exam function is also vision, pupil, and eye movement. So it's either good vision, poor vision, or no vision. So by good vision, I would consider good vision to be 6/12 or better, 6/12, 6/9, 6/6. Poor vision or no vision is a gross assessment of how you can classify it. Whether the vision is equal, what their color vision is doing, which I'll come to later. And surrogate markers for vision is if there's poor alignment or a poor red reflex, it may indicate that the vision is poor as well. Pupil reactive or not, and whether they're equal or not. And eye movements would be full or limited, whether they've got any abnormal eye movements. And a surrogate marker for a misalignment is if the patient has double vision. There are different apps that you can use these days, so you don't have to have a full Snellen's chart. There's a very good app called iChart Pro that you can just download for free on your iPad, and most people have some tablet or some device that they can use it, and they're developed by ophthalmologists. They're free. They can be calibrated for different room sizes. You can even use it with a mirror if you've got a small room to double the distance, and you can even change the alphabets. It's quite a useful app, and it's very handy to use it as a portable eye testing device. Even the Eye Handbook, another free app that you can download both on Android or iPhones. So these are been available for a lot of time now, and they're getting better because they're constantly updated, and you get different color vision tests, near vision tests, pediatric fixation targets. You can check sizes of pupils and do a whole lot of things with it. There's also a bit of information about common eye conditions and how to manage them within it. So the first part of my talk will be the acute red eye and how to go through a diagnostic approach. So if you have a patient with a red eye, the three most important questions I think you should ask the patient is your vision much worse than before? Do you have any pain? And are you more sensitive to light? And if you ever call an eye doctor or call the eye and ear emergency wanting to refer a patient with a red eye, that's the first three questions that we'll ask you over the phone as well. What's the vision? Does the patient have pain? Does he have any light sensitivity? So we'll go through one by one. So the first question that they you should ask is your vision much worse than before? And the patient may say yes or no. So if the patient says yes, then you have to think of what could possibly cause a red eye with poor vision. And the two things again are, is it a structural problem or is it a functional problem with the vision? By structural problem, I mean there's a problem within the structure of the eye that's preventing the patient from seeing, like an opacity, or a functional problem where parts of the eye are not working, like his retina, his optic nerve is not working, and even though his structure is clear, he's not able to see an image. So if it's a structural problem, it could be one of two things, that you can either see it and it's obvious, or it's something subtle and you can't see it. And if you can see it, you should think, is it in the visual axis? Because structural problems in the visual axis are known to affect the vision of the patient. And if it's not in the visual axis, is it still causing some change in the structure of the eye that's causing the patient's vision to be worse? So if you had to make a list of things that could possibly explain a red eye with poor vision with a structural problem that you can see easily in the visual axis, those are the common things that we see. So to list it, it's in the cornea, it could be either opacities within the visual axis or abrasions in the anterior chamber, blood or pus. Iris problems just going from the front to the back again, could be torn, distorted or missing after trauma. The pupil could be round or not. Lens, central cataracts, and red reflex you can compare with the other eye. So these are the things within the visual axis, and I'll give you examples of each. So corneal abrasions are extremely common, and you can have centrally located corneal abrasions like partially obscuring the pupil, or within one edge within the visual axis, or really large ones, or linear ones that cross the pupil. So these are structural things that can be associated with the red eye within the visual axis. But the key thing is, with these, the vision is not that poor. Okay, they could be actually normal vision even with having an opacity in the center, or slightly worse. They would not have poor vision, they would have pretty good vision, 612, 69, 66. And the most common reason why their vision is poor is not because they can't see, it's because they're in too much pain and discomfort to actually give a good reliable vision test. So if you had to check the vision of someone with a central corneal opacity or any corneal opacity, it's important to anesthetize the eye before you actually check vision, because if you make the eye comfortable, then you'll get their actual true vision, what they see. Other things in the center of the visual axis that can cause a red eye with poor vision is corneal opacities, ulcers. These are things that you need to refer onto us because they need intensive antibiotics. So it could be small, medium, large, or just on the a bit eccentric, that's encroaching on the visual axis. These are just examples of corneal ulcers or opacities. Just going from front to back again. Anterior chamber content, if you have blood in the visual axis, either half chamber, full chamber, you could obviously not see. And pus, that's how it looks. So that's a full chamber hypopion or pus in the AC. and a red eye with anterior chamber stuff. That's also something that you would refer to as. The other thing in the visual axis that can cause a structural problem with the red eye, especially after trauma, is a condition we call iridodialysis, where the pupil can tear, or the iris can tear from its root, and the pupil itself comes into the visual axis and can block the vision. Again, going further into the eye, so structural problem with the red eye, especially post-trauma, is cataracts, which you can either see directly. If it's a mature cataract, you'll see a white reflex in the pupil, or even if you're doing a direct ophthalmoscopy, red reflex. If it's not a mature cataract, you should see a dull reflex on the side with the injury. Sometimes even uveitis or inflammatory eye conditions can cause a red eye with a cataract, and that's where the pigment on the iris and pigmentary changes in the anterior chamber are quite commonly associated. And the fifth thing within the visual axis, if you can't see anything structurally wrong up to the pupil, then just do a quick red reflex check, because even if there's a structural problem within the visual axis behind the lens, a red reflex, if you compare between the two eyes, can pick out that one eye might have a duller red reflex, even if they've got a vitreous hemorrhage at the back, or something, infection or vitritis at the back. It will give a duller red reflex in the pathological eye. So that's the list of things in the visual axis. So what are the things in the not in the visual axis that can cause a red eye with poor vision and that you can see easily? Two common things that present to us are opacities in the cornea that are peripheral opacities, and I'll explain how they can distort vision, or conjunctival overgrowth onto the cornea. So typical things that are not in the visual axis but can still cause a red eye with distorted vision is a pterygium. They're generally slow growing and don't present acutely, but sometimes you can get an acutely inflamed pterygium, which can be exacerbated by a dry eye or trauma. That can present acutely. They can distort the vision by actually distorting the cornea. So even if there's not in the visual axis, they can pull on the eye and change the shape or the curvature of the cornea, and patients can feel their vision is worse than before. But again, it's slightly worse. That's the key. It's not tremendously poor if they've got an eccentric pterygium. So it will be again 612 or better, or slightly worse. Marginal peripheral corneal ulcers, so ulcers that are not in the center but also infections or ulcers in the peripheral cornea, can also distort the corneal curvature and cause visual problems with the red eye. Or sometimes they can also incite a strong inflammatory response inside the eye called uveitis or keratouveitis, which could also cause visual problems. So if you see something in the periphery of the cornea, that could also explain a vision change. So that's the list of things you can see, and things that you cannot see easily. That is still a structural problem for which you may need higher magnification or slit lamp, or refer to us. That's what can still explain a drop in vision with the red eye. It's a subtle corneal haze or opacities. If there's a peripheral lens opacity, especially after a trauma where that had a penetrating injury and only the peripheral part of the lens was touched, or if they've got mild anterior uveitis, it's hard to see without a slit lamp. Or any posterior segment pathology, which you're not expected to see, but you could rule it out by a red reflex. So common structural problems that are mild, slightly harder to see are in association with viral conjunctivitis, which I'll come to later in more detail. You can have subtle corneal inflammatory changes, subtle corneal haze that may be hard to pick up with just a torchlight, or even haze that you need to pick up on a slit lamp under higher magnification. As I said, comparing the two eyes is important, because sometimes if you're just looking at one eye at a time, you can miss a subtle haze because it looks fairly clear, but if you look at both eyes together, you may be able to make a distinction that one eye is slightly hazier than the other. Other thing with vision worse and structural problem that you can't see is anterior uveitis, where they actually have an inflammation in their iris and in their anterior chamber. They come in with quite red eyes, and the hallmark of a uveitic red eye is different from an eye that has conjunctivitis, is that the redness is more circumlimbal or closer to the limbus, as you can see in these photos, with the peripheral sclera or conjunctiva relatively being not as red as the circumcorneal limbus. That's because the inflammation is within the anterior chamber, so the blood vessels close to the limbus are the ones that are redder than usual. Anterior uveitis can also be suspected in someone with a red eye who's got a pupillary change, because if the iris is inflamed, they can develop sticky adhesions to the lens called synechiae, like these. So if you see a red eye with a distorted pupil, probably a uveitic red eye. Other things that you may miss is a peripheral lens opacity, also better seen when the patient is dilated. So you can imagine if this patient had a smaller pupil, then the part of the lens that you see through the pupil might be clear. Typically, in an acute setting, you might see post-trauma or post a sharp penetrating injury where the lens has been pranged by an in and out mechanism, even if the original entry wound has been sealed. And posterior segment pathology that can cause a red eye with a structural problem that you can't see are those things, but you don't need to worry about them, because if you're suspecting a posterior segment pathology, you'll be referring them to an ophthalmologist anyways. So that's the list of structural problems. Now, what are the functional problems that can explain a red eye with worse vision? So functional problems is that the eye is structurally normal. You can't see any obvious pathology, but the vision is definitely down with a red eye. So is it because the optic nerve is not working? Is the retina not working? Or is the brain not working? So if the optic nerve is not working, for example, if someone has had a trauma with a traumatic optic neuropathy and a red eye from the trauma, you can probably rule that out with a quick pupil check. Check if the pupil is equally reactive. That's checking the function of the pupils and comparing it to the other side. Is there an RAPD or a relative afferent pupillary defect that can be compared in the speed of the reactivity while shining your torchlight from one pupil to the other? Color vision is a good indicator of the optic nerve function. So if a patient's color vision is worse, probably the optic nerve is not working as well. On the unilateral eye, if it's a bilateral color vision problem, is probably colorblind, but you need to keep that in mind. Visual fields is something we test for in our clinic, but you may not be expected to check it. But gross visual field test, comparing all four quadrants, whether you can see fingers equally in its temporal and nasal quadrant as well as superior and inferior quadrant, is a gross estimate. A brain visual field problem would not cause an RAPD, number one. You wouldn't have a pupillary abnormality, and you wouldn't have a red eye if it's coming from the brain, or unless he's had a massive motor vehicle accident where he's also injured his brain. But with any optic nerve related visual field loss, you would get a relative afferent pupillary defect or a sluggish pupil on the affected side. Retina is not working, the other possibility, but that's hard to distinguish clinically. They need more invasive testing that we do. And I put this in red because this is actually more common than you think, whether the brain is not working. So the eye is red, vision is worse, you can't see a structural problem, he doesn't have an RAPD, red reflex is normal. So why is he not seeing well? Is probably he's faking it. Common in young people who have been punched in the eye, or people looking for compensation, or the other thing is they're just not understood the test. There's a language barrier. They don't know how to do the test. You've chosen the wrong test for the patient, or a young kid who's unable to read, or the patient is in so much pain and discomfort from his corneal abrasion, and you haven't anesthetized the eye, that he's just not able to do a good vision test because of his pain or discomfort. So that's actually the more common than the first two causes. So that comes to, is your vision much worse than before? Those were all the yeses. And if he says no, my vision is not as bad as it was before I had the red eye, so it's probably a structural problem not in the visual axis. It's a structural problem because his eye is red, but because his vision is not worse, can't be in the visual axis. Common things that cause a red eye but don't cause any significant vision changes is conjunctivitis, which is the most common referral we get. Bacterial, viral, allergic, and I'll come to that in more detail. Or dry eyes, blepharitis, episcleritis, subconch hemorrhage, and non-specific red eyes. Very mild anterior uveitis can also cause the vision to remain normal. And if he's got a peripheral corneal pathology that hasn't distorted the cornea as much, you could still have good vision with the red eye, but there will be other markers that are red flags, which I'll come to later. Hence scleritis. So a typical photo of a patient with bad conjunctivitis. So if you can see, his visual axis is quite clear. He's got a lot of redness in his conjunctiva, also not circumlimbal, mainly palpebral. There's also got pseudomembranes, which is quite significant conjunctivitis, and again red eyes with discharge. So with these patients, they could actually say that their vision is not as good, but if the vision is carefully checked by clearing the cornea from any discharge, wiping it nicely, putting a drop of anesthetic, making the patient comfortable, and then checking his vision, you'll find that these patients have quite normal vision, unless they've got a corneal involvement, which also I'll come to later. Subconjunctival hemorrhage, very common as well. So they could be quite scary looking, where the entire conjunctiva is filled with blood, or just a small quadrant. Always have good vision unless it's a bad trauma causing any posterior segment pathology. Episcleritis, also kind of a non-specific red eye, which comes in with focal redness, no vision changes, not a lot of discomfort or pain, and they tend to be either in the palpebral aperture. So episcleritis always generally tends to be either nasal or temporal limbus, rarely superior or inferior, and they can fluctuate with season, with whether the eye is dry or not dry, and they can be recurrent, but they're not serious. They're annoying, but they can be treated with just lubricants and anti-inflammatories. I'll come to that. These are the most difficult patients we get, dry eyes and blepharitis. They keep coming back because they are unhappy all the time. We get a chronic red eye, and we keep sending them back with just lubricants and hot compresses. They come back saying that's doing nothing, and we'll say do more hot compresses and more lubricants, and it's a cycle, but I'll come to that in more detail. But their vision is not bad. Anterior scleritis is the only serious thing that can present with a red eye and good vision, because it's inflammation of the sclera, and it could be quite dramatic, really red. That could look like conjunctivitis, could look like anterior uveitis. But the hallmark is pain. So if they've got pain, that's another reason to send them to us. In really bad scleritis, you could have intraocular inflammation as well that can reduce their vision. So I'm putting it, it's generally not worse. No. So scleritis can be localized or diffuse. So you could get just a local patch of redness, but the clear hallmark is pain. So anything deeper than the conjunctiva that is inflamed, there is pain. So even if it's a sectoral scleritis, touching the eye, or the patient would have pain just as it without touch.
But wouldn't a patient with episcleritis also have pain?
No. So episcleritis patients don't complain of pain. They complain of discomfort or burning, which I'll come to later. And that's important to classify when you're asking for pain. What is the type of pain? So patients with scleritis generally describe the pain as dull or boring pain, and really intense, and worse on pressing the eye. So the question for the camera was, how can scleritis be sectoral, or does the whole eye be red? And the other question was, can episcleritis have pain? So I've answered those. So that was the section on vision changes with a red eye. Now I'll come to the second question, is do you have pain? Okay, and if you have a patient with a red eye and do you have pain, he says yes, I have pain. Again, is it a structural problem or a functional problem? So structural problem causing pain in the eye, there are only certain pain sensitive structures that the eye has. One is the eyelid. So if they've got a red eye with a swollen eyelid, you could have a painful sty on the eyelid margin. That's actually the source of pain, not coming from the eyeball but from the eyelid, so that needs to be carefully segregated. Or the cornea can cause pain, the sclera can cause pain, and sometimes acute glaucoma, or where the pressure in the eye goes too high, the sclera stretches, and that's the reason why they get pain in acute glaucoma. Muscles around the eye can cause pain, so myositis, or sometimes optic nerve inflammation can cause pain, because the meninges around the optic nerve can cause pain. So those are common structural problems that cause pain, and you can see it easily, you can't see it easily, So if it's painful and you can see it easily, it's probably on the cornea or on the sclera. So it's keratitis, ulcers, abrasions, and foreign body, or it's scleritis where the eye is obviously red and painful and tender, or you cannot see it easily. So I'll come to that later. But examples of corneal foreign body are, could be anywhere. They're quite a common picture. So limbal foreign body or within the cornea can cause quite a lot of pain, discomfort, and they typically will describe it as there's something in the eye. So they don't say there's pain, they'll say it's painful, but there's something in the eye. So that's the common terms that they use. Whereas a patient with scleritis will say it's painful. Things that you cannot see easily that can cause pain is foreign body under the eyelid, significant anterior uveitis, posterior scleritis. So the anterior part of the eye is white, but behind at the back near the retina, the sclera is inflamed. Acutely high intraocular pressure can cause pain, again from a scleral stretch or myositis, which photos of. So foreign body under the eyelid, there it is. And ways to pick it up is more often than not, they'll have a fluorescein stain that picks up linear abrasions on the cornea. That is, every time they blink, it scratches the surface of the eye. So you could suspect it if a patient has a red eye with pain, but you can't see anything specific on the cornea. If you stain them, you might see subtle scratch marks. That means you need to flip the eyelid and check for a foreign body. Acutely high IOP, also a red eye, really bad pain. Key factor is that the anterior chamber will be very shallow. We call that acute angle closure. The pupil will be non-reactive and mid-dilated because the eye is just under so much pressure, and sometimes you can have iris changes. But the source of pain is the sclera. Again, I said the muscles around the eye can be painful. So if you've got a patient who's had a red eye and is complaining of pain, the other thing to think of, does he have myositis around the eye? And the other clue for that is that the eye might be slightly proptosed or has eye movement limitation. So functional problem, eye is red and the patient has pain. You can't see any of these. So why does the patient have pain if his cornea, sclera is not involved? It could be one of these, but it could be that he's either misunderstanding pain, and common in kids or people who just use the term pain broadly for any discomfort. Some people say burning, itching, or discomfort for pain, and that's actually quite common. So there are people who say yes to everything. Is it painful? Yes, but what is the type of pain? Is it a dull ache or sharp pricking pain? Actually, it's not painful. It's maybe a bit itchy. Kind of people who come in. So that's pain. And he may say, no, I don't have pain. So again, what doesn't cause pain? So the structures of the eye that are not pain sensitive are the conjunctiva. So if you can actually pick up a person's conjunctiva and you won't feel pain if you're delicately handling it without touching the sclera underneath. And bacterial viral allergic conjunctivitis generally doesn't cause pain until their cornea is involved. Dry eye is again the same list: blepharitis, episcleritis, subconch hemorrhage. Non-specific subconch hemorrhage can also be sometimes describing as a mild discomfort or pain. And again, anterior uveitis and posterior segment structures are not painful unless it's the sclera. So just having a vitritis, a retinal detachment, or a vitreous hemorrhage is not painful. Third most important question, are you sensitive to light? So we come to the third red flag, that's photophobia. So are you more sensitive to light? And the patient says yes. Again, structural and functional. So what are the structures of the eye that can cause light sensitivity? And you can see it easily, generally the cornea, because corneal inflammation or trauma can make the person exquisitely light sensitive. Keratitis, ulcers, abrasions, and foreign body. And you cannot see it easily. The other things that can cause light sensitivity is anterior uveitis. That's another common presentation with them being photophobic, but you may not be able to see it. They could have really bad dry eyes. That's their tear film is breaking up and their corneal epithelium gets exposed to the environment, so they can be really light sensitive. And really high pressures can also cause light sensitivity because under high pressure the cornea can swell up. And are you more sensitive to light? If he says yes, you can't see a structural problem, probably faking it or doesn't understand the question. I put that in. And he says, no, I'm not light sensitive. I can open my eye. And by light sensitive, just one more point. A lot of people are light sensitive out in the bright sunlight anyway, so you shouldn't ask them, are you light sensitive when you go outdoors while staring at the sun? You should ask them, are you light sensitive more than usual in normal room light? Or you could check it in clinic by shining a light into their normal eye and into their inflamed eye. And if they are obviously not tolerating the light in their inflamed eye, they're probably truly light sensitive. Okay, so I've put, are you more sensitive to the light? And he says no. So once again, we come to the same three things. So it's conjunctivitis, dry eye blepharitis, and I've just summarized that. So as GPs, you will be probably seeing or wanting to treat patients who don't have a visual problem, don't have pain, not sensitive to light. And if you see the top two causes in all of those categories, it's conjunctivitis, dry eye blepharitis, episcleritis, subconjunctival are just non-specific. So those are the top two causes that you don't have to worry about, but they can probably need not be referred to an eye doctor instantly. A flow chart for how to go through, which is what I've already told you. So this is quite a good flow chart that should be in the handout, or you can access the video later. So first question, do you have pain? And you can classify the pain further. This is important. So you can ask any patient complaining of pain, is it really pain? Are you having, what is the type of pain? And let the patient describe it in his own words. They'll say it's like a headache, or I feel a pressure within the eye or behind the eye. It's a dull aching pain. If I touch the eye, it's more painful. Or it's a sharp superficial pricking pain, like there's something in the eye, or it's a stabbing pain within the eye. Those are the words they'll use. So if he says yes, there is pain, you have to send them to the eye doctor if it's genuine pain, because as I said, the pain sensitive structures are the cornea, sclera, and you could have other inflammation within the eye. So second question, if he says no pain, do you have blurry vision? He says yes, I do have blurry vision. Do you have light sensitivity? If he says yes, then yes, send them to us, because few structures in the eye are light sensitive. If he says I don't have blurry vision, then comes into the category. So he doesn't have pain, doesn't have blurry vision, and doesn't have photophobia. Then the top causes are conjunctivitis. Then you can ask them, do you have discharge? And he says yes, I have discharge. And then we will speak about this in more detail. Is it purulent discharge or watery discharge? Do you have itching? And we'll come through that part. So that part is what you guys will probably see more commonly. The other important thing is this arm of the flow chart. If there is no pain, no blurry vision, no discharge, no itching, you still send them to us, because they may have part of their eyes inflamed that doesn't cause anything that in the symptoms that are red flags. They generally are not serious, but sometimes can be chronic and annoying. So that's the arm to send them to us. That's the arm also to send them to us. Red flags and red eyes. So just to summarize what I've told you, if there is genuine vision loss, not because the patient has a puffy eyelid with conjunctivitis and you're checking his vision with the eyelid half droopy, that's not genuine. You have to lift the eyelid, watch the discharge, put a drop of binoxynate, check his vision. If it's genuinely low, send them to us. Pain and photophobia. And there's one more red flag that I had included. It would be called proptosis. So if you have a red eye and the eye looks like it's more prominent or being proptosed, then the other things that can cause a red eye is an orbital cellulitis, an acute red eye, where the patient, but there's other signs. The lid will be swollen, the eye will be tense, he'll be unwell, he'll have a fever, his eyelids will be difficult to open, and generally when they have a scan, there is inflammation around the soft tissues of the eye involving the coats of the eye. Or you could have we do get not infrequently, but we could have a patient with an acute red eye who's proptosed, doesn't have pain, fever, swelling, eyelids not difficult to open, but they could have a low flow or a high flow sudden onset carotid cavernous fistula. Key features for that is looking at how tortuous the conjunctival vessels are in that red eye. This is because they've got high venous pressure within their eye circulation as well. So that was the part of the talk on diagnostic approach and red flags. Any questions before I go to the next part about specific eye conditions and how to manage them? you could keep with your phone camera, if you have the light source on at all times, and you actually look on the screen, sometimes before you capture the photo, you might see the red glow in the person's retinas. Some phones have advanced software that when you click it, they will remove the red eye, because you don't want that in a photo. So it's always advisable to look for the red eye before you snap it. Or there are different camera apps that you can download that don't remove the red eye after you have snapped it. Okay, but still the direct ophthalmoscope is the best tool, because that's designed to give you a good red reflex rather than a phone photography. But you can try it. You can see a good red reflex in darkness. So turn the room lights completely off so that the pupils maximally dilate without having to put in the eye drops, and then click a photo. Okay. Sorry, for the camera, the question was how do you check for red reflex with your phone? So common things that you can manage in your GP practice: conjunctivitis, which are 3 broad headings: viral, bacterial, and allergic. So we'll come to viral conjunctivitis, the most common thing that we see daily. So it's the most common referral, I would say. If you're working in an eye hospital or anywhere, I think half of the patients who come in have viral conjunctivitis. It's what it looks like. And the common story is I have a red eye. It started 3-4 days ago. I've been started on Chlorsic, has made no difference. Okay, so viral conjunctivitis, top 3 causes. Then you have other things. So key tips on what to look in the eye to make a call whether it's viral or not. First thing is that the eye is quite red if it's at its peak, but if you look under the eyelids, they always have these tiny follicles, what we call them, where the eyelid or the what we call the palpebral conjunctiva will not be a smooth shiny surface. It will generally have a cobbled follicular appearance. The other key feature is petechial hemorrhages. So you generally don't get these in bacterial conjunctivitis. So if you see a lot of tortuous vessels, a lot of redness with intervascular hemorrhages, there's probably viral. Viral conjunctivitis typically have these blotched hemorrhages associated with it. Membranes, pseudomembranes. So bacterial conjunctivitis have a lot of discharge, but viral conjunctivitis actually have serosanguinous discharge that can coagulate and form a membrane. Also very classical of adenoviral conjunctivitis. So these photos, what I'm showing you, the follicles, the hemorrhages, the pseudomembranes, and in the chronic stage. So these are patients who have whose conjunctivitis has resolved, but the virus still persists in their corneas, causing these spotted subepithelial corneal opacities. The adenovirus, which is the most common viral conjunctivitis we also get, typically has these features which I've just shown you. And if they go into a chronic stage where the conjunctivitis has healed, they could still be left with a bit of photophobia, blurry vision, because their cornea is involved. And this appearance typically happens if they've used steroids. They can also happen if you haven't used steroids, but because steroids can prolong the duration of viral conjunctivitis, we prefer not to use it unless we really have to, which I've put in later, because it prolongs the infectivity period as well as gives them a higher chance of the virus migrating into the cornea and remaining there. Characteristics of adenoviral conjunctivitis: their discharge is generally watery or sometimes even blood tinged or sanguinous, because it's quite common to have bloody tears run down the eye when you've got adenoviral. They've got this petechial hemorrhages, a red eye. Also frequent preauricular lymphadenopathy is associated, and quite commonly temporarily they might have had a sore throat or a bad cold either preceding it or while they have the conjunctivitis or immediately following it, because it's the same virus that also causes pharyngitis and other things. So that was adenoviral. The other viral conjunctivitis that we see can have this quite a classical textbook photo of dendrites on the cornea. These patients are not generally as inflamed as an adenoviral conjunctivitis. They're corneal pathology, and they're not in as much pain or discomfort, because the herpes virus is also a neurotrophic virus, so it kind of numbs the eye as it affects the eye, so they don't have a lot of pain. And if you see an appearance like that, you should ask for a history of this. So have they had vesicles around their eyes or on their lips? Because the same virus, the herpes simplex virus, can cause the eye to be involved, and it need not be in the same episode. So if the eye is red and they've got a dendrite, they could have had an ocular or a lip herpes infection any time in their lifetime. So it could have been 10, 15, 20 years ago, as a child, because the herpes virus never really goes away. It stays in the nerves, and every time your immunity goes down, it does surface. So if they've had any herpetic vesicles on their face in their lifetime, and you see this, it's likely to be HSV. The importance of that is, if you have a good history of having cold sores on their lips or their eyes, it's likely to be a herpetic infection, and the recurrence is likely as well. So they are at lifetime risk of getting recurrent herpetic red eyes. The other is where you get a red eye with a dendrite with the facial appearance like that, which is shingles. That's a different herpes virus called the herpes zoster virus, whereas the initial one is a herpes simplex virus. The zoster virus typically affects the eye if the ophthalmic division, the V1, is involved, but the specific sign is if they've got the tip of the nose involved, which is the nasociliary nerve, they have a higher likelihood of having an ocular involvement as well. So herpetic are generally unilateral. There is an history of vesicular eruption on the eyelid or on the face, either shingles or not shingles. The other thing is that herpes zoster viral infections tend to be active only during the time of the active shingles episode. They don't recur, unlike herpes simplex. Okay, and dendritic, and they can also have preauricular lymphadenopathy. So what can you do if you see a patient with a red eye, you're suspecting conjunctivitis? The first thing is swab the eye and send the viral swab for a viral PCR, a multiplex viral PCR. That looks for adenovirus, HSV, and VZV. If you're suspecting bacterial conjunctivitis based on the discharge being a bit thick or mucopurulent, or bacterial conjunctivitis is also more common in the child, you could send a separate bacterial swab. Or if it's a chronic, discharging eye, it could be viral, but sometimes in a high risk patient, it could even be chlamydial. But we don't routinely check for it unless we have suspicions that it's not getting better or it's behaving atypically. The way to swab the eye is just roll a cotton swab into the most inflamed part of their eye, the eyelids, or if there's a dendrite, then you can directly swab over the dendrite on the cornea, of course with a drop of anesthetic to make them comfortable. You can start them on Chlorsic because there is a small chance that it might be bacterial, and wait for the swab results to come back. Okay? Generally within 24 hours you get a swab result. If it's a weekend, you might have to wait for 3 days. Clean your room, wash your hands, advise contact precautions to the patient, and then look at the swab results. Okay, if you get it the next day, good. And the first thing is, if the swab comes back as positive for a viral infection, if it's the adenovirus, you can stop the Chlorsic because it's not going to make a difference. And the longer the patient uses his antibiotic eye drops, the more chance he auto-infects himself, because every time he's handling an eye filled with adenovirus, putting a drop in transmits to his eye, and it's extremely contagious to have the adenoviral infection. So this is a table that tells us how you should manage it. So things are, if it's adenovirus, enterovirus is quite rare, but adenovirus is extremely common. Almost every patient who's got a non-responding viral conjunctivitis has it, and the treatment, as you see, is nil. So nothing other than hand washing, minimize touching the eye, don't share your towels, pillow covers with family members, and just sometimes for comfort you can give them cold compresses. Very rarely do we need to start them on steroids if they've got other signs of extremely difficult pseudomembranes to get rid of. There's no effective treatment, and some patients do like using artificial tears, but I generally don't prefer that, because anytime they use an eye drop to put in their eye, the chances of them not being meticulous with their hand cleaning is there, which could prolong their infection. So preferably avoid all drops. I'll come to viral conjunctivitis later, that has acyclovir, which I've summarized later in my slides. So if the swab comes back as adenoviral conjunctivitis, no eye drops are needed. Cold compresses for comfort may be advised. And viral conjunctivitis, which is adenoviral, is notorious for lasting long. It can last up to 6 weeks, sometimes longer, sometimes earlier. But the take home message is that in 2 or 3 weeks, everyone is better. So it starts getting better at the 2-week mark. So if you've treated them only for 3-4 days with Chlorsic, it won't work. It has to take up to 3 weeks. And if it's really bad with pseudomembrane, significant eyelid swelling, causing difficulty, then they may need steroid drops. And don't start steroid drops, refer them to an ophthalmologist because they do need monitoring, because sometimes they can get dependent on the steroid drops to keep the eye quiet. It prolongs their infective period, as well as it puts them at risk for developing a chronic adenoviral keratitis. If you are thinking it's adenoviral and the swab results confirm that, you don't really have to worry too much, because even though they're in pain, discomfort and complaining, there's very little risk of them going blind from it, if they can survive the first 2 weeks. Okay? That they should be happier in 2 weeks. Okay, the second swab result that is likely to come back is a herpes simplex viral conjunctivitis. So the question is, how long should they take off work, or how long should children be off daycare? I agree that 2 weeks is what I advise them, and that's the period where they're the most infective. If they have been on steroids, their viral shedding prolongs into 3 into 4 weeks. So if they're off all eye drops, not touching their eyes, then 2 weeks is good. But I tell the parents or the patient that in 2 weeks, if you're no better, then probably take another week off. If they're if they come back as HSV positive, either a dendrite, then you can start them on acyclovir ointment 3% topically for 7 days, and you can probably treat them if they've had a known history of HSV in the past. It's not their first episode, they've come back previously with the same thing. And generally, if it's just superficial conjunctivitis or a single few dendrites on the cornea, you don't have to give them oral antivirals, and they do get better in 7 days or 3 days. And often these patients have had it previously, so they already know that it's probably the HSV virus that's coming back, and they're pretty good at starting acyclovir topically. The oral treatment is sometimes needed if they're getting frequent recurrences, and every time you stop the acyclovir, their dendrite heals, their eye gets better, but it keeps coming back. Or the herpes virus is a lot deeper into the structures of the eye, like the corneal stroma, they're getting scarring. And if it's a stromal involvement with, then we do give a course of oral antiviral. That's the treatment dose of acyclovir, 400 milligrams 5 times a day for 7 to 14 days. And sometimes if they're getting frequent relapses, then we keep them on long-term prophylactic antivirals. So those are the 3 most commonly used ones. And the prophylactic dose for oral antivirals for HSV recurrent viral keratoconjunctivitis is 400 milligram BD, or valacyclovir 500 milligrams OD, famciclovir 250 milligram OD. And these patients could be on months to years of acyclovir, because every time they come off it, they keep getting recurrences. And we generally start them because we have to weigh the risks of chronic antiviral treatment versus how significantly distressed or visually threatening their ocular inflammation is.
Sorry, with the topical acyclovir, is it once a day or twice a day?
It's 5 times a day. Sorry, I haven't put that in, but treatment dose is 5 times a day for acyclovir, but for 7 days, and it almost always gets better if it's just an epithelial dendrite with this. If it's a patient who's known to have recurrent inflammations because of the herpes virus, yes, we do start them on orals, and there are some patients who are have it every 3 months, every 2 weeks, every 6 months, and we do say that you could start oral antivirals before you feel it coming on, so to limit the the scarring or the side effects of the virus infection. But if it's a first presentation, or he's having one episode every 3 years, 4 years, then just oral acyclovir is fine. So the question was, sorry, I keep forgetting to repeat it. Do we start them on oral acyclovir prophylactically? And my answer was that.
Excuse me.
Yes.
Is that available on the PBS?
For herpes simplex, yes. I'll come to that for the zoster. So the zoster is, if it's a shingles episode with a corneal or conjunctival involvement, then you have to start them on oral antivirals because it's beyond the eye. And the treatment dose for herpes zoster or shingles episode is 800 milligrams 5 times a day for 7 days, but up to 14 days if the rash hasn't completely gone away. Valacyclovir 1 gram TDS and famciclovir 500 milligram TDS. Now for this, I think the PBS approval was 250 milligrams for 3 times a day, but that is actually underdosing the patient, and that's, I think the INDA is aware of that, because sometimes we have patients with shingles coming in with the started as 250 milligram TDS, which is what PBS gives approval for, but the dose is actually higher for famciclovir. That's in our clinical practice guidelines at the INDA hospital. So question was for herpes simplex, can we use famciclovir instead of acyclovir? You shouldn't be making the decision to start a patient on acyclovir orals, because the patients who need acyclovir or oral antivirals with the herpes simplex are the ones who are chronic or who have got a more significant inflammation involving their cornea. But if there is a patient who's already on it, yes, and you're just monitoring them, continuing their treatment what we have started, then you could start them on famciclovir 250 milligram OD. That's in the guidelines. Or if you're treating them, I think it's 250 milligram TDS is the treatment dose for herpes simplex. So 250 milligram, 500 milligram TDS is for zoster, 250 milligram TDS is for herpes simplex. So when to refer a patient with shingles to an eye doctor? Basically all patients should be sent in, because sometimes it's hard to assess their actual vision with a really bad shingles episode that's shut their eyelids, and we might have to check it more diligently. But they could also have rare unusual inflammations within the eye or behind the eye that we generally monitor them for. Their eye involvement is generally worst at the peak of their shingles rash, but as their shingle rash improves and their face clears up, they very rarely have any eye problems. So we just say once at baseline within 3 days, and subsequently only if their vision deteriorates once their rash clears up and you can't see a structural pathology to explain it. So sometimes you could have retinitis or vitritis from herpes zoster that needs urgent treatment. So if their vision is, and we tell that to the patient, if your vision deteriorates after your rash gets better or during the course of your rash, then you need to come back to us soon. It's better for us to start treatment with any herpes virus. So adenoviral conjunctivitis is more common. It's rare to get a dendrite. It's relatively fewer percentage of patients who have a herpes simplex keratitis. If you are confident making the diagnosis, the patient's vision is good, doesn't have pain, doesn't have those red flags that I spoke about, you could trial acyclovir 3% 5 times a day. And if it's purely a herpetic simplex lesion that the swab has shown to be positive and he doesn't have any red flags, yes, you could start it. I don't see a problem. It's better because of the chance that every inflammation that they get can lead to scarring, and we just need to monitor them and touch base with them. Generally, if it's only an epithelial involvement, it heals without scarring, there's no long-term problems. But if they're getting recurrent inflammations, or even if it's the first time they've got it, it's better to touch base with us, because we might ask a more detailed history. Have you had it previously? Have you had a red eye previously? And then we can look for other signs that give us clues that they might have had previous ocular inflammation. Okay. So the question was, can you start acyclovir for a single dendrite with no red flags at a GP level? Or do all of them need to be seen by an eye doctor? The answer is yes. Preferably everyone to see an eye doctor. May not be the same day or the same day that you see a dendrite. Could be within the next 3-4 days, just to touch base. The herpes zoster vaccine is now on the immunization program for 70-year-olds. That's so it's probably best to encourage that vaccine, because that's the age population that actually gets it the most commonly. Second, conjunctivitis.
Have you noticed a reduction since the vaccine?
No, it just started I think last year in November, so it's too early to tell. But yeah. Bacterial conjunctivitis, so more common in kids. Quality of discharge is what differentiates it, as well as duration of symptoms. So it's more of a purulent yellow discharge. Both eyes, could be unilateral, bilateral. And again, the treatment is the same. You need to swab them and look for what is causing it. If it's one of these, Haemophilus, Moraxilla, Streptococcus, or Staphylococcus, that they're the more common ones, then you could actually observe them, because if they don't have red flags of pain, discomfort, no one really goes blind from conjunctivitis as such. Or you could start them on Chlorsic. So Chlorsic could limit their duration of illness, but even if you don't treat a simple bacterial conjunctivitis, it is more likely to get better on its own anyways. If it's something unusual like a gonorrhea bacteria, they can actually penetrate an intact eye as well. So it needs to be seen by an eye doctor as well as an infectious diseases person. And chlamydia conjunctivitis is sometimes a rare masquerader. It can be a chronic thing, not getting better, doesn't look viral, bacterial. Chlorsic has made no difference. Then we sometimes swab them to look for chlamydia if there are risk factors, and they need systemic treatment. And we'll come to that later. So what can you do for bacterial conjunctivitis? Keep going on Chlorsic because it does shorten their duration, but probably if you don't start it on it, it's fine. It's likely to get better on its own. When do you refer? If there's a child less than 1 month of age with it, it's more likely to be a more sinister pathogen, and plus their immunity is low, so they are at higher risk of losing vision than someone who's older. And it comes under a different category called neonatal conjunctivitis, so they need to be seen by a pediatrician as well as an eye doctor. Or if the swab shows gonorrhea, or again if there's a red flags of pain, photophobia, or corneal involvement, which most don't have. Allergic conjunctivitis, again red eyes, but a lot of lid signs associated, so they get puffy eyelids, a lot of itching. Their conjunctiva can sometimes balloon up after an acute exposure to an allergen, where the mast cells can degranulate, and it can look quite nasty, but they don't have pain, discomfort, or vision problems, and it's mainly conjunctival. They can have much larger papillae under their eyelids compared to viral conjunctivitis, where they generally have tiny follicles. And characteristic features of allergic conjunctivitis, especially in kids, is that they tend to have this limbal zone of inflamed conjunctiva, and the rest of the eye may not be as red, but they typically get symptoms of photophobia and discomfort because of limbal involvement, and they can get these papillae under their conjunctiva. So if you've got allergic conjunctivitis, cold compresses do relieve some of the itching, and they're more distressed by the itching rather than anything else, and their light sensitivity if they've got corneal involvement. Olopatadine are the safest eye drops to start. They are quite common antihistaminic eye drops that are also mast cell stabilizers that will reduce some of the itching as well as treat the condition. And you can avoid, you can start them on oral antihistamines if they've got other associated periocular allergic rash or hay fever, and ask them to avoid their known allergens if they have one. When to refer? Yes.
Do you give specific advice for allergen avoidance? How would you do that?
If they're constantly getting recurrent, or every season they're getting it, then we might recommend or send them to their GP to advise if they need an allergic skin test or something, but not routinely unless they're really debilitated by it. Especially in kids, we have some kids who have got very strong atopic tendencies where they get bad facial rashes as well as eye involvement, but for an isolated eye involvement, generally not routinely. So the question was, do you do anything specific for allergen avoidance? If the patient knows his allergen, yes, but if not, then you could go down the testing route. So when to refer? If there's a lot of photophobia from corneal or limbal involvement, or if there's no relief in itching and watering with the trial of olopatadine, oral antihistamines, cold compresses is still quite photophobic and itchy, then sometimes they may need steroids, which better for us to start. That's the treatment hierarchy for allergic conjunctivitis. So that's 1 to 4 as the severity, whether there's no corneal involvement, only a few papillae, versus whether their papillae are quite big and they've got a lot of inflammation. The first line of treatment is just mast cell stabilizers, of which I've told you olopatadine is the best one to start because there are very few side effects of that, and it's twice a day eye drop, just once in the morning, once at night. But if it's anything with papillae not getting better with olopatadine, then they need topical steroids or oral steroids or cyclosporin, and if it comes into that category, it's better referred to us because we generally monitor them while they're on their topical steroids. It's quite common for them to need chronic topical steroids, so we have to monitor their pressures and their lenses as well. Yeah, so Chromolite is also a mast cell stabilizer. It is also an anti-LR. You could start that. We prefer olopatadine because it's a newer modality, as it is a dual action as well. So it's also an antihistamine and also a mast cell stabilizer. So it's a dual action. So it's fewer times a day that you need to use it, just twice a day. Question is, any comments on conjunctivitis in contact lens wearers? So if they've got either bacterial, viral, or allergic conjunctivitis, we advise no contact lens wear till their eye is completely better. And once their eye is completely recovered, we would advise starting with a fresh pair of contact lenses, fresh cleaning solution, fresh carrying case for their lenses, just in case they've contaminated their previous pair. Because that puts them at a higher risk of developing bacterial superinfections, even if it's just a viral conjunctivitis and their cornea being involved. So no contact lens wear, and if it's a adenoviral conjunctivitis, then no contact lens wear for 6 weeks, 2 months, something like that. Yeah, so depending on how poor their hygiene is, are there any organisms that contact lens wearers are susceptible to? Yes, they can get Pseudomonas, which is the one that we worry about, because that can also penetrate an intact cornea, and sometimes fungal or acanthamoebal organisms can also be seen in the eye, and we always ask them to bring their contact lens with them, because we send the contact lens off for a culture as well to see they do have more unusual organisms.
And the case.
And their case as well, so the contact lens and their carrying case. So how are we doing on time? So subconch hemorrhage, again, quite impressive looking, but not serious if it's just a subconch hemorrhage, and it could be mild, quite significant, alarming, and sometimes the patient doesn't even know he's got subconch hemorrhage, because someone has looked at him and said, "Hey, your eye's red." And they, "Oh, is it?" And then he gets scared because it looks really red, and it comes in. So what can you do for a subconch hemorrhage? Just reassure, and lubricants, if the conch has ballooned up significantly to impair the spread of the tear film along his eyes. Sometimes he can get a bit of dryness or irritation if the conch is really lumpy. So when to refer a patient with subconch hemorrhage? If the story doesn't match, okay, they've got a significant high velocity eye trauma, they've got a fall to the fall or a punch or a ball or an elbow to the eye, and they've got only a subconch hemorrhage. Or if it's a sharp injury, they've been hit their eye with a knife or a fork or a pen, and you can see only a subconch hemorrhage. Or if their conjunctiva is ballooned up to levels where they can't close the eye comfortably, those are one thing. And of course the red flags of this pain, photophobia, decreased vision, those are when you will be referring them on to us. Blepharitis and dry eyes, very very difficult to treat patients, because it's a chronic condition. There's no satisfactory treatment, and they're always in discomfort, and the treatment solutions for them at this stage are not great. You can have anterior blepharitis, where the eyelashes mainly get crusting every morning, and they get sticky, and all these crusts tend to fall into the eye, and they can get foreign body sensation, and it's always a dirty, gritty eye that they complain of. Or you could have posterior blepharitis, where the meibomian glands that are closer to the eye, they get inflamed, and the meibomian glands are very important in contributing to a healthy tear film. They secrete the oily component of the tears, and that keeps the tears on the eye for longer. So if they've got a blocked meibomian gland, the tears are not healthy, so they end up with a dry eye. And blepharitis plus dry eye can give you a chronic red eye, inflamed eyelids, and cranky patients. The common symptoms are, my eyes water all the time, and we tell them, you've got a dry eye, and they look at us, but my eye is watering, how can it be dry? And then we have to explain to them that, look, your eyes are dry, and in order to treat the dryness, your eyes are reflexly overwatering, but the quality of tears that are produced are not as good as they should be, so they don't stay in the eye for too long. Typically, if you put fluorescein, you'll see these dry spots appear, especially in the areas that don't blink as well. So on the inferior cornea, if that's the most common part to dry out. They use, like, it feels sandy, gritty, feels tired all the time, it's burning, it's itching, it's uncomfortable, I can't work, I can't read. It's quite a wide variety of symptoms. And they can't, sometimes their vision might be a bit low as well because the tear film, which also contributes to the optical clarity of your vision, is poor. It's broken up and they get these dry blotches on their cornea that can cause them real symptoms. So anterior blepharitis, bacterial, they're generally bacterial hypersensitivity proteins that can cause chronic blepharitis. And sometimes we do need a course of systemic antibiotics to eliminate them, but rarely. And that's the mechanism: eyelid irritation, chronic red eye, dry eye. And chalazions are quite common in patients who've got blocked glands or meibomian glands, because a chalazion is nothing but collection of the secretory components of the meibomian glands within it if it's blocked. And they can also get infected and get a secondary bacterial infection. So what can you do for blepharitis dry eyes? You can reassure them, patients, and that's what we do. We say, they come to us and we say, do hot compresses, put lubricants, lubricate your eye, because you need to moisturize your eye daily in order to get comfort. And they come and we say, that did nothing. We used it 4 times a day. And we'll say, okay, use it 6 times a day. Then they say, that did nothing. Then we tell them you can go up to every half an hour, every 1 hour. Lubricate your eyes as much as you need to, because your main symptoms are coming from a lot of dryness. The hot compresses help to open up the meibomian glands, because the heat actually can melt the oily secretions and allow them to reflow normally. If they've got a lot of discharge on their eyelashes, you could recommend diluted baby shampoo to just clean the crusts of their eyelashes. That softens the crust and allows it to be removed quite easily. Flaxseed oil supplement, there's some evidence of that. Incorporating flaxseed oil in your diet improves antioxidant levels that give you a better tear film. And black moors can, there's commercially available flaxseed oil supplement that they can include. Environmental humidifiers reduce screen time. It's actually quite common to get a lot of dry eyes in this day and age, because there's mobile phones, laptops, tablets, screens all the time that you're working on, and that tends to blink. You tend to blink infrequently when you're engrossed in screen time, and if you already have tendency for dry eyes, that exacerbates it. And you just ask them to blink regularly, because with every blink the tear film spreads onto the eye. When to refer? Vision loss, all of those red flags, because they can get bad corneal involvement from being constantly dry all the time.
Sorry, how dilute should the baby shampoo be?
Yeah, so the question is, how dilute should the baby shampoo be? So we recommend 1 in 4 dilution. So for example, Johnson's baby shampoo, we ask them to take 1 cap of the baby shampoo, mix 4 caps of hot water, create a nice frothy solution using a bit of cotton or cloth, dip it into it, and over your closed eyelashes, just wipe it off. So the shampoo component actually softens the crusts. It's very hard to remove it without plucking your eyelashes out. And they just need to do it daily. And they're not happy with the treatment option, because they say, how long do I need to use lubricants for and do hot compresses for? And we, in our mind, we're thinking forever. But we tell them at least a few months. So if you see, there are a lot of FDA research in dry eye, because it's such a common problem, and they're quite unhappy patients, keep coming back, frequent visits. There are different devices that to make hot compresses more appealing. So LipiFlows are things that come into the market. They're still not in common use, but they are FDA approved, and they're just electronic devices to heat up the eyelids. But hot compresses are simpler. Corneal abrasion. So I think I have 10 minutes to go. 15? Okay. So corneal abrasion, other common reason for eye referrals. Hallmarks are vision not too down, but a lot of pain and discomfort. Complete relief in symptoms with topical anesthetic eye drops. There's no need to patch the eye to treat them. You can give them prophylactic antibiotic eye drops, though it doesn't accelerate the healing. Whether or not you give them chlorosic drops and ointment, they're going to heal anyways. Even the largest corneal abrasions, if they've got a healthy cornea, will heal within a maximum of a 5-day period. So they do start healing. Small ones can heal within 24 hours. Bigger ones within 3 days, large ones within 5 days. And if the mechanism is suggestive of a non-penetrating injury, I'll come to guidelines on when to refer, then you can just treat them at your level. You don't have to send them in. Prophylactic antibiotics reduces the risk of an infection because they've got a corneal abrasion, but as I said, not absolutely needed. So if the mechanism is consistent with the corneal abrasion, if they've been injured with a finger, a nail, a paper, a blunt injury, and you can see a corneal abrasion, there's no need to refer because it's probably what it is. But if it's a child and it's an unwitnessed injury and you see a corneal abrasion, it's better to refer, because sometimes if no one has witnessed the injury, it could be anything, and there might be a secondary deeper component to the injury. If the mechanism indicated a sharp high velocity trauma and you see only a corneal abrasion, also keep a high index of suspicion. And the key factor is that topical anesthetic should take the pain almost completely away in a pure corneal epithelial abrasion. And if they're significantly photophobic, even after numbing the eye, then you need to refer, because it's probably not just a corneal abrasion. Fluorescent stain can just show how large or small it is. And treat with Chlorsic eye drops or ointment and review in 48 hours. So the worry with corneal abrasions are it can get infected. And even if you have a corneal abrasion that's fresh, it takes at least 48 to 72 hours for it to get infected. It doesn't get infected on day one. So you could safely observe these patients and review in about 48 to 72 hours. If it's small ones or healing, they're probably already better by the time you see them. So if they are better, you can continue to review another 48 to 72 hours till they completely heal, up to a maximum of 4 to 5 days. If they haven't healed within the 5-day mark, refer to us. And if it's not better or worse in 48 hours, then you need to refer to us. If it's a simple abrasion getting better, they will be better in 48 to 72 hours. They may not be completely pain-free, but you can ask them, are they 50% better, 70% better? And if it's getting better, you can observe, yes. So we use oxybutyric, that's what we use, or even alkane is fine. So question is, how do you know whether they're better? What are you monitoring? So also the size of the abrasion, if it's definitely getting smaller, their symptoms should also be getting better, and the symptoms of pain and the photophobia is better. They'll still have some pain and photophobia, it is if it's not completely healed, but there is a correlation. So small abrasions have less pain and photophobia. A larger abrasion exposes more corneal nerves, so there'll be more pain and photophobia with larger abrasions. So yeah, a bit of both. So the question is, can they take home the topical anesthetic? Answer is absolutely no, a firm, resounding no, because there are patients who self-medicate with topical anesthetics, and that makes their cornea completely numb. So you could probably drive a knife through their cornea and they wouldn't feel anything. So even if they're getting a bacterial infection, they wouldn't feel the pain of it getting worse, and it can mask more serious eye problems. Plus, long-term topical anesthetics can also induce corneal toxicity. They're not designed for daily use or frequent use. They're just designed for once use because they are epithelium toxic and they can slow the healing of the abrasion. The last few topics are episcleritis. So also in conjunction with dry eyes, these non-specific rednesses, they're not vision threatening, not serious, but can be annoying for the patient. And as I said, they are in the palpebral aperture. What to do? Just lubricants, cold compresses. Sometimes, because it's an inflammatory pathology after all, you could give them oral NSAIDs to see whether it gets better with that. But if it doesn't get better, or they're still quite annoyed and looks scary, then you can refer to us, because then we might use topical NSAIDs or steroids. Yes, sir.
Do children get episcleritis?
Rare. So it's more a common condition in adults. Children are more likely to get dry eyes. Last part is trauma of the talk, and I'll go through it quickly because I have 10 minutes. So 3 types of trauma: chemical, blunt and sharp. Chemical injury, quite common, and the take-home message is irrigate. If you see someone who's had an alkali or an acid splashed in their eye, just irrigate. Before you ask anything, just start with the irrigation, because that's the most crucial to outcome. Okay. Studies have shown that if you start irrigation after exposure, the quicker you start irrigation, the better it is for the long-term patient. And you could use basically anything: saline, Hartmann's, tap water, just whatever liquid you can find that's not toxic. And the end point of irrigation is till the pH is fairly within normal range. So we consider 7.5, 7, 7.5, 8 to be within normal range. If it's close to that, it's fine. Or best is to compare it to the other eye, which has not had the chemical exposure, and it should be equal to the other eye. That would be the ideal endpoint. If it's a particulate matter, powder, or lime, then you need to evert eyelashes and sweep out any obvious particulate matter. You could wash the eyes constantly, and alkalis are more dangerous because they can penetrate the eye rather than acids. And the other risks are, if their vision is down, which generally it is because they're in a lot of pain and discomfort, it's better to send them to us, and I'll tell you when to send them to us. A completely hazy cornea is quite a bad sign. So significant corneal injuries, they can burn off the entire epithelium as well as the blood supply that nourishes the epithelium. So if you see a cornea like that, you have to refer to them because it's quite bad, and even we find it difficult to do anything. You can check pH with pH strips. Even urinary pH strips are fine if you don't have eye strips like these. The one thing that you need to know is that with badly burnt eyes or with chemicals, you can have the entire eye stain, and if you're used to looking at corneal abrasions that are small focal staining on the cornea, you might actually pass this off as normal, as the entire thing just pooling with fluorescein rather than true staining, but it's actually whole eye can stain, so you might not see a focal area of stain, which sometimes can look quite deceiving. So refer ideally only after the pH has equalized to normal after irrigation, because if there's a break in irrigation, it'll it's not good. And even if the pH has not equalized after 30 to 60 minutes of irrigation, then you need to transfer them to us while they're being irrigated along the way. Okay, so in an ambulance, or just get someone, a family member or relative, to constantly irrigate them. Other associations of blunt injury with a red eye is abrasions, traumatic iritis, mydriasis, hyphema, vitreous hemorrhage, retinal detachment, or globe rupture. And you need to refer everything to us other than a corneal abrasion. And it'll be obvious. If you see a pupillary size change or blood, you send them to us. Last part of the talk is sharp injury. So most common objects are do-it-yourself tools, home tools, hammering metal on metal. Most common is a metal chip going into the eye. But other sharp injuries, forks, knives, screwdrivers, drill bits, needles, pens, pencils, falls into sharp rocks or bird or twigs, bird injuries, hard-bound book covers. I've seen 3 of those. Cat scratches, dog bites, quite common, motor vehicle accidents, stones being thrown, and explosions. So I'm going to go through a series of gory images. So staple guns to the eye, quite common. We do get one of these, a couple of these every year. Fish hook to the eye, nail guns going through the eye, things that are almost completely in the eye and you can just see a small bit sticking out. Magpies are actually not. So there's one thing that I've realized that in Australia we do get a lot of magpie injuries, at least 2 or 3 every year during magpie swooping season. They actually tend to attack the eyes, which I didn't know before I came here. So
Excuse me.
Yes.
Explain a bit more, because quite a lot are involved in it.
Magpies?
Yeah.
Yeah, so there's a swooping season where the magpies are nesting between August to when springtime comes, when winter is getting over and the weather is improving. That's when magpies are breeding, and they if you accidentally walk near a nest, then the adult magpie can actually swoop from ground up and attack the eyes. They just tend to attack the eyes. So if you see bikers actually wear helmets to protect them, because they tend to bike in paths close to nests, and sometimes the nests are actually on the ground, so not up in the tree, so you might actually pass them while just walking casually through a park. And it's not uncommon. We do get a few every year.
What's the management? I might see one every week.
Of magpie. So if it's really badly injured the eye, you need to send them to us, because not infrequently they have got either a bad abrasion with a fingernail or beak that could be at a higher risk of infection from fungal or unusual organisms, but we also get penetrating injuries with the beak or the claw within the eye. If it's just a skin abrasion, sometimes you can just get a flesh wound around the eye, and that can probably be managed by you, unless it's a deeper injury affecting the eye.
So what's the management?
If it's a penetrating eye injury, we need to repair them in theatre. Otherwise, a lot of antibiotics, a lot of close monitoring if it's a abrasion, just because they can get fungal and other unusual corneal infections. Yes.
There are some online, some websites that actually indicate where there are problems with magpies.
Yes.
Cyclists use.
Yes.
Cyclists actually magpies to their helmets.
Yes, so they do. You have to draw eyes on the back of your head, and there's things that can deter a magpie. And there is a website that if someone has been attacked, they will put it up on the website that avoid this park. A magpie has swooped, and I think council authorities can take care of that. Sometimes we get them in clusters because a group of people have gone through the same area and the same magpie has attacked 3 or 4 people. So we sometimes get a few of them coming in. Important to have high suspicion with high velocity injuries. So
Slide.
oh yeah, so this is a penetrating injury. So that was the pupil hanging out of the eye. So that's iris tissue outside the eye after a sharp injury. So this pupil is gone. Sometimes with a high velocity needle injury, very little external signs. You may just see a subconch hemorrhage, but the most of the thing might be inside the eye. That's why, as I said, if you just see a subconch hemorrhage, but it's a high velocity injury, you need to have a high threshold to send them to us. Other things to look for: if there's a large subconch hemorrhage after a blunt or a sharp injury, look for if there's any brownish pigment under the blood, whether the anterior chamber is shallow. Those are clues to an underlying perforation under the conjunctiva, where the conjunctiva is intact but the eye has ruptured from below it. Okay, so shallow AC and brown pigment. Other thing is pupil distortion, quite common after you had an occult penetrating injury. If you see the pupil being drawn to the part which has had the injury, then the pupil might look oval or abnormally shaped. That's where the pupillary red flag that I told you, the structure of the eye that you need to look for. And the simple test that you can do, sometimes the injuries can be so occult, like a needle stick injury, that you might see that the cornea is intact, but you might see a defect in the iris, like a stab wound through the iris. The way to pick it up is by doing a simple fluorescein test. So you can put fluorescein on the eye, and if there's an opening in the surface of the eye, the aqueous generally leaks out, and you can see an area where the dye looks like it's swirling because aqueous is constantly coming out of it. So that's one way to test for small leaks after an injury. So that's called the Siedel's test. What can you do with a penetrating injury? So fast the patient because he'll need surgical repair soon. Put a shield on the eye that doesn't actually physically touch the eye, because any pressure on the eye can actually worsen a penetrating injury if there's so either make a shield with a cup, or if you have ready shields that actually don't touch the eye, better. If it's a long way away, you could give them tetanus, because sometimes very commonly they get dirty injuries with sticks and stuff that could cause tetanus. And if they're quite nauseous after an injury, it's best to give them anti-emetic before you send them, just because if they vomit and their eye is open, then they could lose some of their eye content. So it's always, and what not to do is don't pad the eye that way, because sometimes you get pressure and that can actually aid in ocular content coming out. Okay, so that's my talk. Preferably after 6 months and more, because we don't have the facilities to examine really small eyes here, so it's better seen at the children's hospital. Having said that, if we do have a kid come into our emergency department, we'll have a look at them, but more often than not, if they have an eye problem, we send them to the children's anyways, because we don't have pediatric anesthetics in case they do need a surgical intervention. After hours or even inpatient facilities for kids are not good if they're really young. So if you have a kid under the age of 1, I would say, who has an eye problem, better to send them to the children's hospital, because we have more facilities and better examination there. So flash burn are typical high light and heat intensity injuries that are seen in welders or people who have been welding things, where intense heat and bright light can actually damage the epithelium of the eye, but the epithelium of the eye may not shed off until later. So what happens is that there's a intense heat injury to the eye, and that kills off the cells of the eye, and then 24 or 48 hours later these patients have intense pain, because they've basically lost their epithelium, and they get a corneal abrasion finally. That's the mechanism. And the treatment is just the same for any corneal abrasion. You just need to give them a lot of antibiotics and monitor them closely every 48 hours. Their corneal abrasions tend to be quite large because their entire epithelium generally sloughs off, so it might take up to 5 days for them to completely recover. But we don't manage them any differently from any other corneal abrasion.
They're not to have topical anesthetic.
Yes, and they are not supposed to have topical anesthetics, the flash burns, because for home use, you could put one drop in to examine them and put the fluorescein in, but they are quite uncomfortable just because how large their epithelial injury is, basically almost total. But there's no risk for them losing vision compared to a chemical injury where the cornea has burnt off completely, because in chemical injuries they tend to also lose their blood supply to the eye, whereas with flash burns it's only the surface that gets burnt, the deeper vessels don't get burnt, so we don't really see long-term visual complications from flash burns. Ideally, for patient discomfort, we could pat the eye, but we prefer putting bandaged contact lenses in to give the patient comfort rather than actually padding the eye, because sometimes padding the eye can be counterintuitive. It acts as a focus for bacteria to grow, and plus the patient can't monitor his own visual recovery. So we like the patient to have his eyes open, see whether he's getting better, feel the comfort level of his eye and tell us voluntarily. But if he's in a lot of discomfort, we prefer putting a contact lens in the eye. Yes, because it will tell you which virus, and it gives you a kind of reassurance that this is the adenovirus and it's likely to get better. Herpes virus are recurrent, so you'll have to tell the patient that it's probably going to come back if in the future. So it's always good to know. You could also have a swab negative where the virus is not detected, not uncommon, but we still treat them with the clinical features rather than the swab results. If you are safely confident that you can remove a superficial foreign body, if you've done it before and you know how to do it, then yes, you should attempt it. Especially, it's no problem in attempting it if it's in the peripheral cornea and if you've done it before. But if it's in the central cornea in the visual axis and you've never done it before and you're not confident, then better to send them to us. Because if you're deeper, you could theoretically create a scar, even though it's relatively a safe procedure. With corneal foreign bodies, they can sometimes, if it's been there for more than 24 hours, it can leave a rust ring, which is the harder bit to remove. It's where the metal oxidizes and stains the cornea. So if you're able to remove the main part and the patient is presented within 24 hours, the rust ring comes off as well quite easily, and you could go fishing. But if it's a deeper rust ring, the foreign body has been there for 3 days, 4 days, then you probably may not be able to get all of it out. And even if you remove some, enough to give the patient comfort, and then we can do the rest, if needed.
So do you give any process eye drop?
Yes. So if you remove the entire foreign body, you could use fluorescein eye drops, because more often they have a small corneal abrasion in the area where they have the foreign body, and just with any corneal abrasion, you could give them fluorescein till it heals, even though it's not really needed because it will heal anyways. But it's safer to use fluorescein.
So how about iPads?
No iPad. We don't put any iPads on any patient.